Dear committee members, dear audience, colleagues, welcome to my 3-month progress report presentation. My PhD topic is about key differences in sex-specific outcomes after anterior cruciate ligament reconstruction surgeries. My name is Krisztina Kornis. I'm a physical therapist and a first-year PhD student. Here you can see the individuals supporting me during my journey, and we work towards my vision, which is revolutionize physical therapy assessment and treatment with innovative methods. And my mission to achieve it is to explore innovative strategies in physical therapy by conducting research. To achieve my goals, I have 2 ongoing projects at the moment. Both of them are analyzing sex-specific outcomes after anterior cruciate ligament reconstruction surgery, with a particular focus on graft failure and arthrofibrosis. Let me introduce you both of my projects after each other. My first project is investigating the effect of sex on the outcome of anterior cruciate ligament reconstruction surgery. This is a systematic review and a meta-analysis. Anterior cruciate ligament is a double-bindle dynamic ligament which maintains knee stability during dynamic movement. Only in the United States, there are more than 100,000 ACL reconstruction surgeries in every year, and the incidence of a second ACL injuries in athletes after the first ACL reconstruction is nearly 6 times higher than in healthy controls. Despite the high prevalence, while investigating the literature, I realized different sources publish different results. Some articles mention that both sexes have a similar chance of experiencing a second ACL injury, and some authors mention that female players have a higher rate of secondary ACL injury, and some papers mention that males have a trend towards higher re-injury rates. We know that anatomical differences, hormonal effects, biomechanical factors, and variations in neuromuscular control can influence the success rate of ACL rehabilitation between sexes. But what are these effects and what are these factors? Here you can see the quadriceps angle and the dynamic knee valgus. Quadriceps angle plays an important role in knee biomechanics. We know because of anatomical reasons that females have a higher quadriceps angle than males, and one of the most common altered movement pattern is dynamic knee valgus, which is often associated with a higher quadriceps angle, which can increase the risk of non-contact ACL injuries in female athletes. Higher estrogen level can also increase the risk of ACL injury due to the hormone's effect on laxity and neuromuscular control. Some authors mention that there is a need to recognize the different factors that can influence the success rate of reconstruction. Therefore, my aim is to identify if there is a difference in the clinical outcome after ACL reconstruction between males and females. My clinical question is if there is a difference between males and females in the clinical outcomes after anterior cruciate ligament reconstruction. I aim to investigate patients who have undergone ACL reconstruction, and I compare males to females. I identified 2 outcomes. The first one stands for the graft failure outcomes, like graft tear and revision surgery, and my second outcome summarizes the knee instability outcomes. My hypothesis is that females have worse clinical outcomes than males after the reconstruction, and it's an important question because if we prove this is true, then we can immediately start developing sex-specific protocols for rehabilitation plans, which may enhance the success rate of ACL reconstruction. In my search key, I identified 4 domains. The first and the second stands for the ACL and the surgery, and the third domain summarizes the outcomes. My 4th one stands for the sex differences, and the search was conducted in 3 databases. My search key led me to find my key articles, which meant that the project is feasible, and it was important for us to find articles which provide separate data for males and females. I found 11,500 articles, and after the duplication removal, I ended up having 7,700 articles. The project passed the feasibility check. The Prospero was submitted at the end of November, and the duplication removal is completed. Now we are working on the title and abstract selection. My second project is about investigating the effect of sex on the prevalence of arthrofibrosis after anterior cruciate ligament reconstruction surgery. Arthrofibrosis is an abnormal fibrotic response which can lead to excessive scar tissue formation in the joint. The most common complaints are discomfort and stiffness, and the incidence of arthrofibrosis is between 1 and 12% after ACL reconstruction in the US every year. While the majority of the patients can be treated with non-surgical management, like physical therapy and mobilization, around 4% of the patients need surgical treatment, like revision surgery or scar tissue removal. Arthrofibrosis can significantly impair functional outcomes and prolong the rehabilitation, and my aim is to identify if there is a difference in the prevalence of arthrofibrosis after ACL reconstruction surgery between males and females. My clinical question is if there is a difference between males and females in the prevalence of arthrofibrosis after anterior cruciate ligament reconstruction. My PICO framework is pretty similar than in my first project. Instead, here as an outcome, I identified arthrofibrosis and revision surgery due to stiffness. I hypothesized that arthrofibrosis is more common in females than males after ACL reconstruction surgery. Why is it important? Well, because by understanding sex-specific risk factors for arthrofibrosis, we can guide the development of rehabilitation programs that are optimized for men and women. Here you can see my preliminary search key. It was conducted in 3 databases. And it also led me to find my key articles. And similarly as in my first project, here it was also the main focus for us to find articles which can provide separate data for males and females. As a summary, I would like to highlight that currently there are very limited sex-specific protocols for musculoskeletal surgery and rehabilitation. And throughout my projects, I aim to address this gap. The planned submission dates, March 2025 and September 2025, serve as the key milestones, and it also keeps me focused on achieving my goals. I truly believe that we all have to be innovators in our field. Therefore, I would like to thank you for your attention with one of my favorite quotes: "Do not follow where the path may lead. Go instead where there is no path and leave a trail." Thank you.
Thank you so much. I can see there are some questions, please.
Thank you for the presentation. I saw that in your first article you mentioned as an outcome returning to sport. This can happen, obviously, at a certain period of time after the intervention. How do you address the follow-up for marking this event? Is there any cutoff point after you say, no, that individual will not return to sport, or how would you address this?
Thank you for your question. First of all, I would like to highlight that the time after the surgery is not as important as objective clinical measures like objective strength assessment of the athletes, where we can actually calculate limb asymmetry or limb symmetry index, which is very important. But in general, I would say that around 9 months, 12 months, the athlete can reach these milestones, and then they can get back to sport. But as I mentioned before, it's more important to screen the patient objectively to reach the strength and movement related criteria before they can get back to sport. And it's also because it's a very multifactorial decision. I would also want to say that it depends on what athletes are you working with. So, for example, an equestrian athlete can get back to the sport at an early stage, but for example, a soccer player or a basketball player really needs to reach these criteria.
So for a simple perspective, this outcome is kind of a result of outcomes previously measured.
Yes, but in my first project, we set a time limit for follow-up for 24 months. So because in 2 years, you can really get the outcome for graft failure, because at the beginning of the rehabilitation process, you don't put your athlete to high-intensity exercises, so that would not make any sense. So this is why we decided to have the 2-year follow-up.
Thank you so much.
Thank you.
Thank you for the answer. Next question.
So, as we know, there are a lot of different types of grafts. Do you plan to compare these different graft types?
Thank you for your question. Yes, there are many types of grafts that are currently being used by surgeons after ACL reconstruction. And we decided to involve all these graft types in both of our projects. And we're planning to do a subgroup analysis later on.
Super. Next one. Yes, Sevda, please.
Thank you. I was wondering, both projects are very similar in that both of them are investigating the ACL reconstruction outcomes, but is there any specific reason that you are not including arthrofibrosis as part of your first project's outcome?
So why I didn't include it in the first?
Yeah, why is it a separate project?
Thank you for your question. The main reason for that is because graft failure, like graft tear, is a long-term outcome, but arthrofibrosis is a short-term outcome. So arthrofibrosis can occur around 1 week or immediately after the surgery. And if we would include arthrofibrosis in the graft failure project, then we would immediately exclude those patients. So we couldn't, because in the first project, we set the inclusion criteria as no revision surgery for the patient can be. So if the patient had a revision surgery, then it cannot be evaluated for the graft failure.
Yeah,
did I answer the question? So it's a shorter short-term outcome.
Thank you.
Thank you for the important clarification. Next question.
You mentioned that you'd like to address the sex-specific rehabilitation protocol after ACL reconstruction. Can you give us some examples of what it could look like in life?
Thank you for your question. Yeah, I think it's very important to address this question because it's very important currently in the clinics. And I would like to answer this question with an example. So I just read a couple of articles which are analyzing biomechanical factors of female athletes in jumping and landing movements. And they analyze these females during their menstrual phase in the cycle and then later on the ovulation phase. And they actually found a difference between these two stages in the female cycle. So they found the laxity of the knee, the instability of the knee is different, and they also use different movement pattern to achieve the same task. So if we could address the rehabilitation plan based on which phase the female athlete is currently in her cycle, then we may be able to enhance the rehabilitation.